Hello, everyone, and welcome.
Hey, good afternoon.
Good afternoon, everyone.
Hi, everybody.
Good afternoon, everybody. We're going to start in about maybe 3 minutes. We're just going to try to get everyone on board, and then once we get everyone, we'll begin. Just as a note, I know that we have booked 2.5 hours today. We're not going to be spending that much time at all. Today's session may be about an hour in length, based on some of the new changes that we've just received over the last couple of days or over the last week or so. So I'm just going to kind of go through the weeds with those ones. And again, as I stated, it won't be 2.5 hours. More than likely, it will be about maybe an hour, if so much, with questions and answers. So no need to worry about being here for 2.5, guys. And we'll start in about 3 minutes. Perfect.
Thank you, everyone, for joining. So if you have any questions or any technical difficulties, feel free to send me a private message.
Thank you so much, Samar. All right, guys, just give us 1 more minute and we will start in 1 more minute. Samara had sent about another 6 or 7 emails out this morning for other requests. So there are about 6 or 7 other people that should be added to the numbers. Okay, I think maybe about a minute's gone by here. I think we should start. Good afternoon, everybody. As you already know, most of you already know, my name is Dale Moses. I'm the Community Support Services IPAC consultant for the region. Today, what I'm going to be discussing with everybody is some of the new directions and guidances that have been set forth by the Ministry of Health and Long-Term Care over the last couple of weeks, even over the last couple of months, pertaining to masking, screening, and other IPAC measures which have been recently revoked. So today's session, as I mentioned at the beginning, we are not going to be here for 2.5 hours, more than likely an hour at the most. After my presentation, as Samara has already stated, please, any questions or answers, please feel free to put up your hand at the end or send a personal link in the chat to myself or to Samara. We'll respond to that at the end. Just as a housekeeping note, today's session is recorded. And this is one of, I believe, 3 or 4 sessions that we'll be having over the last coming weeks. And then in August as well, what we plan on doing is having some more detailed sessions pertaining to some specific topics in IPAC as we get ready again, as I like to say, for outbreak season. But this year we want to make sure that we're on top of everything and everyone's well trained and understands the importance of these measures being implemented for outbreak season. So without further ado, I'm going to begin our presentation. So today's contents are going to be on COVID-19 vaccination changes. So there are some slight changes to the vaccine. Nothing of dire importance in that we'll get to that a little bit later on, but no big changes, but there have been some smaller changes here and there to the vaccination policy. Screening and surveillance updates. We're going to be talking about some of the changes in screening, which we've already talked in the past, but we're just going to go through this again because I did note that there are a few facilities out there that are still, they still have implemented active screening. We're going to talk about masking for visitors, staff, and volunteers, and then maintaining mask-friendly agencies as well. What is it that I mean by maintaining mask-friendly agencies? We're going to get into that too. Physical distancing and cohorting, group activities, new staff return to work policies, and then what we're going to touch upon after that is any questions or answers that you may have for myself. So first things first is COVID-19 vaccination changes. As I've already outlined to everybody just now, there aren't that many big changes to this at all. Mainly that we still continue to strongly encourage that all team members, clients, residents, and visitors stay up to date with their vaccines. This provides, again, as we've always mentioned in the past and still mention now, the best protection from the most serious effects of a COVID-19 infection. Now, the big change here is what's going to be in the vaccine. I know myself, I do consult with other facilities in Toronto, long-term care homes, and this has been a question or concern. With the new vaccine, we're trying to get everyone, we're recommending that if you haven't received a booster within the last 6 months, that you receive one now. But there's also a little bit of a discussion as to should I wait? With the booster that was originally put out for us, it did not have the prevailing strain at the time, which is Omicron Kraken. So with the new vaccine that will be coming out closer to the winter time, which is roughly anywhere between September, October, they have stated that in that new vaccine, they will have the more prevalent strain. The only issue with that right now is there is another variant of concern that has popped its ugly head, which we've been discussing and dealing with over the last few years with COVID. This new one's called X-ray Bravo 116 Arcturus, which is the new name for the new variant of concern. And there has been some concern in that this new variant will be the prevailing strain. So the powers that be, National Advisory Committee on Immunization, Health Canada, as I said, the powers that be are in big discussion with the vaccination or vaccine companies in determining what it is that we want to ensure is in our new vaccine to help protect those that are infected with COVID. As usual, there is always going to be some form of protection, even though the variants might not be exact. So that is up to discussion. It is being discussed right now, and we'll get more of a positive or of an outcome, what's going to happen with this discussion, whether or not we're going to have this new variant, which is they're predicting going to be the prevalent strain, or we're just going to be comfortable keeping the Kraken variant, which is X-ray Bravo 115 within the vaccine. So those are some of the highlights that have been happening underneath the vaccine component of changes. Again, as usual, individuals at increased risk of severe illness due to COVID-19 infections, including those in long-term care homes, should be advised or receive a bivalent booster this spring, provided 6 months has passed since their last vaccine dose or confirmed COVID-19 infection. So as we always say, every 6 months we should try to get a booster, and in helping ourselves to fight or protect ourselves from COVID-19. One of the reasons why things are getting better for that within Canada for that is because of the great uptake in vaccine. We've had at least well over 80-something% of Canadians have at least received one vaccine, which is good news. However, the question which is always asked is, yeah, I received my one vaccine, how much protection am I really getting? And that is truly a legitimate question. That I do not know the answer to, but I can honestly say from reviewing many journals, we will not be receiving that much protection with just 1 or 2 vaccines. It is still recommended that we receive the booster every 6 months to help ensure that we have the circulating strain, or protection from the circulating strain, given the time period that we receive that. So again, always remember the COVID-19 vaccine reduces the risk of severe outcomes in all high-risk persons. So that's usually the main reason or main sell of the vaccine. It's not like, if you get vaccinated, you're protected fully. You still might get it, but the outcomes of severe outcomes, of the chances of severe outcomes are minimized based on the COVID-19 vaccine. And those are only really the true changes that I've noted in terms of vaccine over the last little while that I thought that our group should be updated in. Another one is passive screening. Of lately, this came out as of March 30th, 2023. And I know a lot of us have already implemented this within our agencies. We were told that, or it was prescribed by the ministry, that active screening was no longer required and that we can go to having passive screens. The reason why I put this on here today to discuss is we do still have a few facilities that are still doing active screening, and are looking at going to a more passive screening criteria within their own organization, which is highly recommended in that it's a hard sell to be able to rapid antigen test staff or even clients when the ministry or long-term care homes, CLSs, and hospitals are no longer doing it. So again, what I just wanted to talk about is the differences between the types, which are passive versus active, and just to ensure that everyone understands that the route to go is more of a passive screen now. The numbers are low. I always say COVID is ubiquitous in our environment. People are getting infected. I have a good friend of mine who is a journalist for a National Geographic, and she just came back from Norway and she picked up COVID. And she's had it about 3 or 4 times already based on traveling abroad. So it is ubiquitous in the world. It's still out there. People are still getting infected. But if you're vaccinated and you try to protect yourself, you do minimize that chance of severe outcome, and you also minimize that chance of risk of spreading. So as I was getting into March 30th of 2023, we all reverted from no longer being required to perform active screening on our staff or our clients. I had a lot of questions. Dale, what is the difference between active and passive screening? I know I did send out a general information sheet a few months ago to everybody outlining that, but I'll just review it again, what the differences are, and just let everyone know here on this table today that active screening is no longer required. If you want to still maintain active screening, you can. However, getting rapid antigen tests may be a bit of a challenge. I think the ministry has stopped giving them out as well, and acquiring them or sourcing may be an issue. So again, with that being said, active screening, it means that an employer must collect and review all information to actively determine whether an employee can enter their workplace. An example of an active screening is provision of rapid antigen testing for clients and staff, dependent on the agency. RATs are done to determine if the client or staff are positive for COVID-19. This is supported to ensure that all clients and staff are safe while at an adult day program class. This helps the agency to keep the site safe from asymptomatic or symptomatic persons. Now, again, as I stated, that has been dropped. We are no longer required to do active screening. We are now being pushed to do passive screening. And what is passive screening? Passive screening occurs when employees assess their own risk factors and determine for themselves or decide for themselves whether they may enter their workplace. This is also performed daily to ensure that there are no symptomatic persons at the site. This also helps to minimize transmission by stopping those who may be sick from entering the site. So passive screening now gives the responsibility to the individual. This individual who may work within your organization now has to understand that they are responsible to determine whether or not they have any symptoms that are indicative to not just COVID, but any other respiratory symptom or even gastrointestinal symptom, which would deem them sick, and at the same time, force them to stay home as well. And we'll get into the return to work policy, which is a really good caveat to this, but we'll get into that a little bit later on. But at the same time, if you are sick, you have any type of respiratory symptoms, doesn't really have to be COVID. Good best practice is to stay home to ensure that you do not transmit what you have to others, be it COVID, RSV, rhinovirus. I can go on for days. But now we are being forced, not forced, but being pushed in a gentle and a nudge to now do passive screening at all our locations. Those who are still doing active screening, I would never tell you stop. If you have the source, you have the meetings, and you have a reason, you believe that your clients are extremely vulnerable, and this is something that you wish to maintain, you still can maintain it. I always say that we never know what's going to happen every outbreak season, because during the outbreak seasons, things do get worse. Things may change, and a lot of times these measures that we've been revoking may be implemented again. So again, as I always say to everybody, stay tuned. We'll see what happens in a few months. Process screening also provides individuals the information to monitor themselves for COVID-19 symptoms, and they are not permitted to enter the agency or programs if they are feeling ill. Signage at the entrance and throughout the agency listing signs and symptoms of COVID-19, information on self-monitoring and steps that must be taken if COVID is suspected or confirmed would be a great idea. All visitors entering the home or facility should adhere to the home's visitors policies where applicable. Ensure masks are available for those who choose to wear them as well. And ensure staff understand that they are not to come to work if experiencing any symptom, and to return, as I mentioned, as per agency return to work policies. Masking. This is the gold question that I've been asked multiple times at every level, every institution or facility that I visit. When do I get a chance to take off these masks, Dale? And a lot of it's been coming from the staff because residents or clients were not required to wear masks from time, only based on whether or not they can tolerate or whether or not it was an internal policy made by that agency. So a lot of prayers have been answered for those who do not like wearing the masks. Effective June 30th, 2023, and I've mentioned this already at another table just the other day. Guidelines around masking and distancing have changed in Ontario in accordance with the ministry's direction. All community support services agencies are asked to apply the new guidance as follows. And it's just as community support services agencies, it's long-term care homes, retirement homes, and congregate living settings, CLSs, have all been asked to apply this new guidelines to their establishments or to their facilities and organizations as well. So what is being said? Masking for caregivers and visitors, including staff members as well. Masks are recommended, but not required in all areas of the agency or home. Caregivers, visitors may now join in for dining and sharing a meal or beverage in a communal area in CSSs, long-term care homes, RHs, and CLSs. So if you have a facility, you are not required to wear a mask anymore. Masks are not required. They are optional, and we are hoping that all of our facilities or agencies are mask friendly as well, which I will get into a little bit later. So if you have a facility or organization that says, hey, you know what, we want to abide by this, we no longer want to force our staff, or sorry, I don't want to say force, but require our staff to wear masks, you still have the option of taking it off or even wearing it. And when I talk about mask friendly, we're still allowing staff, if they feel uncomfortable, to still wear masks. I'll give you an example. Long-term care home in Toronto that I used to manage called me a couple of weeks ago, and we're discussing this whole new guidance. And what they plan to do within their organization is to still have staff wear masks only when they're monitoring more than 1 or 2 clients who may be positive for something that isn't COVID or may have some form of respiratory symptoms. So if you're in a facility or you have an ADP, community support services program, CLS, or anything of that sort, where you have people who may come in who are ill, it is perfectly fine for staff to still wear their medical masks when they're working, or even residents, clients, or volunteers for that. In outbreak situations, however, or if a client resident is on additional precautions, all individuals are required to comply with masking and other personal protective equipment requirements, we call it PPEs, as directed by the outbreak management team in the local public health unit. Now, this might be a little different with us. I know in the onset of everything, workplaces were under outbreaks and public health responded to that. I don't think it'll ever get back to that anytime soon. I know with our community support services agency, ADP, we really don't have outbreaks within them. I know there may be some CLSs on board at this table today or at this session. So for you, CLSs, if you're under outbreak, where a client or a resident is deemed sick or ill and is under additional precautions, that is only the time when masks will be worn within your facility if you have now adopted this new Ministry of Health guidance where masks are no longer required. Again, medical masks are still recommended. We have no problems with people wearing it. A lot of times it's a comfort issue. I myself, whenever I visit a facility, it could be a hospital, long-term, anywhere else, I still wear my mask as a precaution. I understand my body, I understand what I go through. I'm diabetic, so I really want to protect myself as well. So a lot of times it's left up to you and based up to your own personal tolerance and your own personal opinions as well on this matter. N95 masks as well, N95 respirators to be used when providing support to a client or resident who is COVID-19 positive if the client is attending a program or a suspect or probable case of COVID-19. So if we're in a situation where we have a client who is visiting, who we've just deemed to be ill, and there is a slight possibility this person could be positive for COVID, it is a good practice to wear an N95 respirator when providing any form of support, or when you're close to this person within, 2 meters for long periods of times greater than 15 minutes. It's great practice and best practice to ensure that an N95 respirator is worn when dealing with this person and providing any form of support as well. Masking staff, students, volunteers, and support workers. Masks are no longer required again in administrative and staff-only areas, lunchrooms, administrative offices. Should be made available for those who wish to still use them. So, again, as I stated, we're still going to ensure that our facilities or agencies are still mask-friendly. However, they're not required at all in an administrative area and staff-only areas such as lunchrooms as well. Masking in client or resident areas will be based on point of care risk assessment consistent with existing routine practices. So those of you who are nurses or healthcare professionals, prior to providing any form of support, and I mean that's including ADP, we do it in our head sometimes. We do something called a point of care risk assessment or point of care assessment. And what this is, okay, I'm going in here, I'm going to be dealing with this person. What is it that I'm going to be doing with this client? What is it going to be doing with this resident? Am I too close? Well, I'm going to be very close to this person for greater than 15 minutes. Then what type of PPE should I wear? What type of additional precautions should be taken into consideration? So again, as stated, a point of care risk assessment has to be implemented or done prior to dealing with this client or the staff member. And once that's determined what you're going to be doing, then you'll decide whether or not a mask is required, a medical mask, or even an N95 mask is required. A PCRA must be completed by every healthcare worker before every client-resident interaction and tasked to determine whether there is a risk to healthcare worker or other individuals of being exposed to an infectious agent, including COVID-19. Because there's other things out there. And as I always mention to everybody, we're trying to move away from COVID-19. There are other viruses and diseases that we deal with out there. Just the other day, I was dealing with an RSV outbreak somewhere. I had another rhinovirus. I had an HMPV outbreak the other day as well that someone had called me about. So there are other things out there that are deemed dangerous as well that aren't COVID-19. So again, as I mentioned, the PCR must be completed by every healthcare worker prior to every interaction. And it has to be determined an appropriate IPAC measure to be taken. Staff may consider wearing a mask during prolonged direct client-resident care defined as one-on-one care with 2 meters of an individual for 50 minutes or longer. So again, as I mentioned already, if you're going to be dealing with a client, if you're a CLS and you have residents or clients, you may call them as well, and you're going into a room where a person is going to be, where a person is possibly sick, you're going to be close to 2 meters for longer than 15 minutes, then I would take proper precautions and wear a medical mask, or depending on the situation of this person, an N95 respirator. Maintaining mask-friendly organization. So this is a big one. The organizations that I deal with for IPAC as well, they've become mask-friendly. So what they've done is posted mask-friendly posters around their organization facility, outlining to everyone who visits or even works there that their facility is open to individuals wearing masks if they feel that that is going to protect them as well. So I have no problems with that. It's actually a very good idea because there are a lot of people, including myself, who are very willing to wear medical masks when visiting facilities or even at work. If I had to work somewhere where I had to stay on site, I would wear a medical mask as protection still. So in alignment with the clients and residents' rights, most organizations will accommodate this. Any staff member who chooses to continue to wear a mask beyond the minimum requirements is encouraged to do so. Any client or resident or substitute decision maker who requests that a staff member wear a mask when providing care or in close proximity to loved ones is perfectly fine as well. And post mask-friendly posters in your organization to reinforce this message to all team members, clients, residents, and visitors. So it's not a bad idea to post this around, outlining that you're perfectly fine with anyone wearing masks. There is no recourse or reprisal or anything of that sort if you decide to wear a mask in your organization or your ADP or community support services agency as well. All right, social distancing and cohorting. So with physical distancing and cohorting, there are no longer any COVID-specific restrictions related to physical distancing or cohorting when an organization is not in outbreak. Each organization does reserve the right to encourage social distancing if clients served are high risk and require extra IPAC safety precautions and measures. So this is completely up to you. Again, the Ministry of Health is no longer requiring or recommending that physical distancing or cohorting be administered in any organization, be it, again, as I'm going to say, long-term care homes, CLS, RH, even community support services agencies and ADPs as well. So there are no longer any COVID-19 specific restrictions for this. So if you are going to have anything within your organization where there are multiple people and they're going to be in close proximity to others, a lot of times what I tell a lot of people is the passive screen, if done properly and reminded to those individuals who are coming into your organizations, as long as they understand that they're going to passively screen themselves and they do it correctly, again, that will somewhat minimize that risk. But we also have to understand right now we're in the middle of summer, people are outside, the numbers are coming down somewhat, and we're expecting that there isn't that much COVID out there for it to be an issue. But again, as I always say, and I said it already at the beginning, COVID is still ubiquitous out there in our community and in our environment as well. So again, just to reiterate what I just said, physical distancing, there's no longer any COVID-specific restrictions for this at all within any organization, be it CSSs, CLS, RH, or long-term care. Group activities, another big one. I get a lot of calls. Dale, I want to have a group of singers coming in. I want to play bingo. I want to have some group activities. We're getting tired of this. We were stuck with this COVID the last 3 years, haven't done anything. And I keep on telling everybody, you're free to do what you want. When you're not in outbreak, there are no restrictions related to group activities and visitors, which may, sorry, something's just blocking me here. And caregivers may join clients, residents in group activities, including enjoying food and beverages. So when not in outbreak, which again, as I stated, none of us really are going to be in outbreaks. That's pretty much most of the time. There are no restrictions related to group activities at all. So if you want to have someone come and play bingo, you have no problems at all. You want to have them come in and sing and not wear a mask because it's not required, that's perfectly fine again. What I would always recommend everyone to do is just, if anyone's coming in, remind them to passively screen themselves. And if they are feeling ill, have any signs or symptoms of anything respiratory or gastrointestinal, to please stay at home until you're feeling better. But again, group activities have stopped. Group activities should still take into consideration the level of risk posed to clients if providing supports to a vulnerable group, and group activities should always be assessed for risk. So As much as everything's opened up, which is perfectly fine, which is fine. And again, this is within, I'm talking about my experience in conversations with a lot of other organizations who have said, listen, I understand this fully. I am going to open up. I am going to have my bingo within my facility. However, this is my only issue. I do not want anyone to come in here who's sick. So my biggest thing, as I just said already, is, hey, if that's your biggest concern, make sure you're asking them to passively screen themselves. And even yourself, when they come in, go and talk to them, visually look and see, do they look do they look sick? Do they look ill? Are they feeling well? There's nothing wrong with asking those questions at all yourself. So again, group activities are now opened up. You can start having your bingos, you can have your singers, you can have your artists who can come in and perform, and there are no restrictions on those people at all either. All right. New return to work policy change. So I've been reviewing policies. Everyone's policy tends to be different. Everyone picks and chooses what they wanted to take from the Ministry of Health guidance for long-term care homes and use, which is perfectly fine, because a lot of that information, as I always say at every table, it trickles over to us as well, and it becomes applicable to us as well, because we are forward facing and we do see a lot of these clients in our organizations for our out-of-day programs. So staff with COVID-19 may now routinely return to work once they are no longer have a fever and their symptoms have been improving for 48 hours. Upon return to work, they should follow measures to reduce the risk of transmission for 10 days from their symptom onset or positive test, including wearing a mask and distancing themselves from others before they remove their mask. So for example, to eat or drink. So this in a nutshell states that if you are sick with COVID and you've been tested positive for COVID or you have symptoms of COVID, you can return to work once the fever and symptoms have begun to improve for 48 hours. So fever stopped, symptoms improving for 48 hours, you can return to work. The only thing that we ask that you do when you return to work, if you've been tested and you're positive for COVID and you meet this criteria, we're just asking you to wear a mask to help protect those who are around you. So I get a question, level 1, level 2, level 3. Just the other day, I had a facility that had a big pod full of level 1 masks, and I was like, that's perfectly fine to use. There is no criteria stating that it has to be a level 3 or level 2. Level 1 masks are just as good. It's just the issue of absorption. Whenever you get splashed on is the problem, is the reason why we have these masks leveled or risk leveled as 1, 2, and 3 as well. This direction is aligned with most current practices of remain off work until 5 days from the onset of symptoms of a respiratory illness or until 48 hours after symptoms have resolved, whichever is shorter, or as directed by your local public health authority as well. So again, if you are sick, you have COVID, you can return to work after the symptoms started to improve and the fever's gone, improving for 48 hours, you can return to work as long as you're wearing that mask for the remaining 10 days while you're there. And a big change that has occurred as well to our area is a lot of the COVID-19 information that we are dealing with now has now been moved to Ontario Public Health Standards requirements for programs. It's called an appendices or Appendix 1. If you want any information pertaining to COVID or any other coronavirus, I've dealt with MERS-CoV in the past. I've dealt with SARS-1 many decades ago. So if you have any information pertaining to coronavirus, COVID-19, MERS-CoV, SARS-1, anything of that form, everything has been now condensed into this one document, which is great, and it does give you really good information pertaining on IPAC measures and preventing yourself and protecting yourself from COVID and any other infectious disease that's from a coronavirus class of virus as well. So it's a really good read. It's quite a big document, but if you need any updated material, this is where you're to go as well from now on for those updates. Sorry, just bear with me for a quick second. And that is pretty much it in terms of all the major updates that we've seen. I know that the biggest one was the masking update that I just spoke on. Again, as I said, now things have opened up. I know that the ministry is trying their hardest to go back to business as usual, but with some form of IPAC measures implemented. So in other words, yeah, we're getting rid of masks, but we're giving you the options, and we're hoping that your option will be to still use the mask when in an area where there's vulnerable people. Again, as I stated in the past, I know they want to go back to the business as usual prior to COVID. I don't think we'll ever get there again because, I mean, things may be looking good right now, but we do have another strain, a variant of concern that they're keeping their eye on. Good thing though, numbers are coming down. They typically come down anytime summer comes around because we were in the same boat last year. But we're hoping that this year around with proper vaccination uptakes, with people understanding the importance of wearing masks, we're hoping that it may not be as bad as we have thought in the past. But on the other hand, there are scientists that are saying, hey, you know what, we've revoked quite a few of these mandates. Masking was the big one that we're hoping that we would keep on for good going forward. However, this too has now been revoked and made optional. So their thought is come outbreak season, things may pick up again and may get really bad based on the concerns that now individuals are given the opportunity to make that decision on whether or not they want to wear masks. I myself, being an IPAC person and consultant, I also work as a manager director for infection prevention control. I have issues with it too as well, and those are just my professional opinions. In that, with the numbers the way they are, they're not that high, but coming to outbreak season, we may experience influx of new cases of COVID-19 and other things such as RSV, being that masks aren't being worn anymore, and that's by the resident, client, and that's also by the staff members. So, I mean, going forward, I think every individual organization should have the opportunity to make that decision on whether or not they still want to comply, or whether or not they feel that, hey, you know what, I think my clients who I serve are very vulnerable, and I still don't think I'm comfortable with removing masks completely. You're completely within your own right to do that. However, you have to understand that there may be a little bit of pushback because people do understand that out there in the community, it is no longer a requirement. So if you are going to be going down that road, by all means, feel free to give me a call as usual, and we will discuss it as we usually do. But that is it for today in terms of any of the bigger changes. If I do know of any newer changes that are coming down by the ministry, I will send off a email to the group or to everybody outlining what these changes are as soon as possible. And regarding this presentation as well, I will send it out to everybody today. I did send someone an update, a document this morning, and asked them not to share it with everyone as yet. But I will send out the slide deck for this for everyone to take a look at and to use if they're looking at getting rid of this mask mandate and other things as well. And just as a reminder, before I get into questions and answers, there will be other sessions. These are more detailed sessions based on control measures. So that will be next week, Tuesday. I'm just reminding everybody as well as we go forward. But are there any questions that are out there for me?